Good evening to everyone. Good evening to everyone and welcome to today's wonderful evening. The NEETPG 2020 at last is over. We are back into the reality, and there are different reactions. Few people are happy, few people are unhappy. That's very common after or unhappy every NEETPG exam. The sad part of the story, so the sad part of the story is the number of seats are limited, the number of applicants are huge. So those who prepare with a lot of focus, they are ultimately going to crack with certain amount of luck, of course. So with that preamble, I like to tell for those people who could not do very well in the NEETPG, don't worry. The next INICET, the next NEETPG are anyway there in the upcoming days. And for those who really did the NEETPG very well, congrats to them. And I'm always there with you to give you company, to do revision with you every day. This is Dr. Murli Bharadwaj. So let's revise few points in general medicine. So this is a classical clinical vignette. So nowadays the NEETPG, next exam, INICET, everything is oriented to ask the questions with clinical vignettes. The patient has evidence of current or previous infection with hepatitis virus. He has Raynaud's phenomena, palpable purpura, neuropathy with hypocomplementemia. That means there is a immune complex formation which is happening. So the examiner is going to give you these clues and ask you to find out what is the clinical condition for the diagnosis. Any of you would like to bet on this question? You can punch your comments. So this is mixed essential cryoglobulinemia. So what are cryoglobulins? They are the immunoglobulins that precipitate in the cold. Now, what are the conditions which are associated with the cryoglobulinemia? Autoimmune hemolysis, Raynaud's disease, which can lead to ischemic necrosis of the digits, acronecrosis, vasculitis, peripheral neuropathy, glomerulonephritis, hepatosplenomegaly, All this can accompany cryoglobulinemia is what you need to remember. There are 3 types of cryoglobulinemia that every NEETPG next to INICET aspirant should know. Type 1, 2, 3. Out of that, which cryoglobulonemias are associated with HCV? Type 2, type 3 cryoglobulinemia is associated with HCV is what you need to remember. So if you look at the types of cryoglobulinemia, you have type 1, type 2 and type 3. Type 1, monoclonal immunoglobulin associated with multiple myeloma and Waldenstrom's macroglobulinemia. Whereas the type 2, type 3, both of them are associated with hepatitis C, don't forget. Type 2 is with even hepatitis B. And type 3, whenever chronic inflammation or any lymphoproliferative disease is there, then it is associated with type 3 cryoglobulinemia is what you should remember. Another important thing, type 1 it is only a monoclonal immunoglobulin, whereas type 2 is polyclonal immunoglobulin G and monoclonal rheumatoid factor IgM is what I want to underscore to all of you. Now, how do you diagnose cryoglobulinemia? Number 1, history. As you can see, previous infection of hepatitis virus with Raynaud phenomena, palpable purpura, neuropathy, so history. Then if you do skin biopsy, if there is any purpura, that will also give you a clue of the presence of the vasculitis. Similarly, hypocomplementemia and the presence of the cryoglobulins, that gives the diagnosis of cryoglobulinemia is what you need to remember. So how do you diagnose cryoglobulinemia? Hepatitis C, serology. And if there is an acute cryoglobulinemia, it can lead to renal impairment, severe renal impairment. Or if there is any acronecrosis, then the treatment of cryoglobulinemia is plasmapheresis. If it is not really that acute, you can treat with prednisolone, cyclophosphamide. Prednisolone, cyclophosphamide are considered to be effective. Chlorambucil is also used with some success. If the cryoglobulinemia is secondary to HCV leading to cryoglobulinemia, then you can treat the HCV with pegylated interferon alpha and ribavirin is considered to be the part of the treatment is what you need to remember. And one important thing about ribavirin, R for ribavirin and R for renal failure. You should be very careful to use ribavirin in the patients who are having the renal failure is one of the favorite MCQ of the examiner. Now, let us take up the next question. A 30-year-old businessman developed a sudden onset of fever, sore throat, diarrhea, myalgia. What is the main differential diagnosis? Infectious mononucleosis, CMV infection, and acute HIV infection. Any of them is possible whenever a businessman recently visited Bangkok, sudden onset of fever, sore throat, diarrhea, myalgia means you should think of all this. Now, why these 3 are differential diagnosis? Because all these 3 are associated with sore throat, with the rash, with the fever, with the atypical lymphocytes. But mouth ulcers are usually absent if it is Epstein-Barr virus or CMV. Then another thing, infectious mononucleosis does not lead to rash as such. But if you happen to use ampicillin to treat the sore throat, then it can lead to an idiosyncratic reaction. Whereas If a patient of HIV, acute HIV infection also will have fever, sore throat, diarrhea, myalgia, etc. In him, if the rash develops, you should think of seroconversion of the HIV is what you want to underscore to all of you. Then coming to the rash in CMV infection, you should remember the rash of CMV space the palms, space the soles is what you need to remember. So summarize, doctor, one of the favorite MCQs of the examiner. How do you differentiate between infectious mononucleosis and HIV? One thing is onset. Abrupt onset is HIV. Mouth ulcers are HIV. Rash usually secondary to ampicillin infectious nucleosis by HIV seroconversion in HIV. Diarrhea more in HIV. Tonsillar exudates are more in infectious mononucleosis. The WBC count is elevated in infectious mononucleosis. Atypical lymphocytes are frequent in infectious mononucleosis. Transaminitis and thrombocytopenia can occur both in infectious mononucleosis and HIV is what you need to remember. Now let us take the next case. A 69-year-old woman with rheumatoid arthritis with swollen ankles. Very important clue. So pedal edema, swollen ankles, rheumatoid arthritis, you have to really worry about. She was diagnosed to have rheumatoid arthritis about 18 years ago. She is very well controlled on NSAIDs until 6 months ago. Then this joint pains and swelling required, she was added with penicillamine. So now the discussion comes. What is the cause of the swollen ankles, pedal edema in rheumatoid arthritis is my question to all of you. So whenever a patient has heavy proteinuria, recent history of swollen ankles, shortly after starting penicillamine, you should always think of one important complication. Penicillamine-induced membranous nephropathy is what you need to basically remember. Very good to see 4 online classmates. Very good, doctor. Very good. Very good. So, every day evening 7 p.m. we have a live class for 1 hour. It is completely free. And if you want all our video library, question bank, mock tests, flashcards, PowerPoint slides, notes, just you need to pay 1999 rupees and you get access for 3 years access you will get on the INCUS quiz app, in the INCUS app. So please take every chance to subscribe to INCUS app. Just for 1,999 you will get everything, 3 years access. Now proteinuria, because of the penicillamine, generally resolves if you stop the drug. Similarly, any heavy proteinuria in a rheumatoid arthritis patient means you should think of membranous nephropathy. That can even happen with gold therapy. Similarly, rheumatoid arthritis is what, doctor? It is a chronic inflammation. Chronic inflammation. A chronic inflammatory state can lead to amyloidosis. So renal amyloidosis is a recognized cause of the heavy proteinuria. So in this case, why do you think it is a penicillamine-induced membranous nephropathy? Because after starting the penicillamine, this has happened. That's the reason this could most likely to be a drug-induced membranous nephropathy is what you need to remember. Now my question to all of you. What are the various causes of the renal disease, rheumatoid arthritis? Why they end up in renal disease? For the pain, they use analgesics that can lead to analgesic nephropathy. Similarly, focal segmental glomerulonephritis can occur because of rheumatoid arthritis. Similarly, rheumatoid vasculitis can be there. But in all this, you will find hematuria compulsory. So analgesic nephropathy is usually secondary to NSAIDs and also paracetamol. And but analgesic nephropathy is unlikely to lead to heavy proteinuria in nephrotic syndrome. That is one point to remember. Similarly, FSGS, it is rare, and if it is there, you expect hematuria. So, rheumatoid vasculitis, there is a predilection for skin and peripheral nervous system, and unless the rheumatoid arthritis is very severe, if there is a nodule formation, high titers of rheumatoid factor, hypocomplementemia, then you think of rheumatoid vasculitis is what you need to remember. Now, let us take up the next case for this today's evening. So don't worry about what happened in NEETPG 2021. Yesterday is forgotten. Tomorrow is not guaranteed. What matters is today, where we are living, that is important. You are not all alone there. We are with you before exam, after exam, except during exam, right? Now, 63-year-old female presented with weakness of both the legs. An MRI scan of the spine is being shown to you. So what is the cause of her symptoms? So you are able to see the lesion, right? So what is this? This is a metastatic spinal cord compression, classically. Metastatic spinal cord compression is what you are seeing here. So what is this image? First of all, it is a T2 weighted image. Always remember, T1 weighted image is for anatomy. T2 weighted image is for pathology. You'll remember, right? T1 weighted is for anatomy, T2 is for pathology. Easy to remember. So basically, this is a T2 weighted image that shows that there is a cord compression from a collapsed thoracic vertebra. And the vertebra in this question, it is infiltrated by tumor. The vertebra, it appears white. The vertebra above is also infiltrated with tumor. So that is the reason it also appears white. And the vertebra below the collapsed vertebra, it appears normal. That means black. So you should remember, T1 weighted images, they provide the anatomical information. So typically in a T1 weighted image, if there's a low signal, which is black, or it can be intermediate signal, it will be gray, high signal, it will be white. So cortical bone, A, rapidly flowing blood and CSF, they all give low signal, black. Gray matter is darker than white matter, intermediate signal. Fat in the bone, scalp and orbit, that makes them to give a high signal, which is a white signal in T1. So T1 is for anatomical information is what you need to remember. Then what is T2 weighted imaging? T2 होता है pathological information. It can be low signal, intermediate or high signal. High signal, CSF or water. Intermediate signal, white matter is darker than gray matter. Low signal, black, cortical bone, air, rapidly flowing blood, hemosiderin, very important, hemosiderin. That is T2 weighted imaging, it will be black. So don't forget one of the favorite MCQs in the radiology, doctor. Now, the next favorite question of the examiner is lobar functions. You have to be 100% sure on them. Difficulty to sequence the task, executive skills, frontal lobe. Expressive Broca's aphasia, frontal lobe, because inferior frontal gyrus is Broca's. Broca's is non-fluent labor halting speech. Frontal lobe, if it get affected, the frontal lobe, that lead to disinhibition, perseveration. That's what you need to remember. Similarly, anosmia and primitive reflexes like positive grasp, pout reflex, palmomental reflex, they all appear frontal lobe lesions. And if you ask him to generate a list, there is an inability, frontal lobe. Personality will change, frontal lobe. That's what you need to remember. Then what is parietal lobe lesions? This is one of the favorite MCQ in the next NEETPG. Next NEETPG. There's a sensory inattention, apraxia, asterognosis, inferior homonymous quadrant anopia, neglect, mild hemiparesis. Parietal lobe lesions also lead to ataxia, acaloclia, and Gerstmann syndrome is what you need to remember. One of the favorite questions of the examiner होता है, भैया Gerstmann syndrome क्या होता है? Any lesion of the dominant parietal lobe lead to Gerstmann. In this, there is an alexia, inability to read, acaloclia, inability to calculate, finger agnosia, and right-left disorientation constitutes Gerstmann syndrome. Any unilateral impairment, whenever the dominant parietal lobe is involved, there is a unilateral impairment of the optokinetic nystagmus. So normally, if you put one rotating drum, that will induce a nystagmus. It is a normal thing, but that side, if the parietal lobe is affected, then unilateral impairment of optokinetic nystagmus is a feature of the parietal lobe lesion. So any person damage to the right parietal lobe leads to visuospatial defects, so that the person cannot navigate around locations, especially in places that are new to them, but even in the familiar locations. Then doctor, what happens if temporal lobe lesion is there? You should remember PITS. PITS क्या होता है? Parietal lobe lesion lead to inferior homonymous quadrant anopsia. Inferior homonymous quadrant anopsia. Temporal lobe lesion lead to superior quadrantopsia is what you need to remember. So when temporal lobe lesion lead to Wernicke's aphasia, and the word substitution, neologisms, and a jargon, meaningless, fluent speech, whereas Broca's is non-fluent. And superior homonymous hemianopsia. I told you now, PITS. Temporal lobe lesion lead to superior homonymous quadrant anopsia. Auditory agnosia, prosobagnosia, difficulty in recognizing the faces. Then finally comes occipital lobe lesions. You get homonymous hemianopsia with the sparing of the macula. And also, occipital lobe lesions lead to Anton's syndrome. Bhaiya, what is Anton's syndrome? The person has blindness, but the patient is unaware that he is blind. He denies that he is blind, which is called Anton syndrome. Similarly, cortical blindness, visual agnosia, visual illusions, elementary visual hallucinations, they're all the features of hospital lobe lesions. A patient is diagnosed with glioma in the parietal lobe. What does he develop? He develops a calyclia. Because just before we read that, parietal lobe lesion patients will develop a calyclia. So it's very common in the NEETPG, next to PG, INICET, all these exams, lobar dysfunction. The lobes in the brain, you have to be 100% sure about that. So before we say goodbye to the today's evening, let us quickly summarize medial thalamus, mammillary bodies, Wernicke-Korsakoff syndrome, subthalamic nucleus, heavy varicose, caudate nucleus, Huntington's chorea, substantia nigra, Parkinson's disease, amygdala lead to Kluver-Bucy syndrome. So what is Kluver-Bucy, doctor? Hypersexuality, hyperorality, hyperphagia, visual agnosia, and increased activation to the amygdala. There is a depression. Any hippocampus pathology lead to short-term memory impairment, as what you see in Alzheimer's. Lateral geniculate body visual field defect. Red nucleus will lead to tremor, which is present both in the rest and also during action. So generally resting tremors are all Parkinsonism. Action tremors are all cerebellar. Both the action, both the rest, that is red nucleus lesion, and commonly multiple sclerosis patients with a demyelinating lesion of the red nucleus will have both the resting tremor, also the action tremor. Any prefrontal cortex lesion that lead to disinhibition, problems of social interaction and judgment, they're all seen in schizophrenia. Left prefrontal cortex that lead to development of depression. Now, if you look at the anterior hypothalamic nucleus, it is very important for thermoregulation and circadian rhythms. And these important neurological site of lesion is one of the favorite topic. So, doctor, after the completion of NEETPG 2021, in fact, that is the 2020's NEETPG, इस साल का NEETPG जनवरी, फरवरी, मार्च कभी भी हो, हम तो तैयारी करना पड़ेगा. So every day evening, Dr. Murli Bharadwaj will be with you 1 hour to spend in your preparation, and you can ask any question during Dr. Murli Bharadwaj show. Good night and see you all tomorrow at 7 p.m. Thank you.